Okay, evening everybody. My name is Karim and I'm one of the ACP Trainee Committee for the South East of Scotland, and together with Ella, who is an ACP trainee in Severn, we are very happy to welcome you to our webinar today, which is on gynecological cancers. And very happy to welcome Dr. Walther and Dr. Alison Stllie here with us. And now to introduce our first speaker, who is Dr. Alison Stllie, who is an excellent consultant working with me at the Edinburgh Cancer Centre. Full disclosure, she is a clinical oncologist, but we won't hold that against her. She specialises in the treatment of gynecological cancers, primarily cervix and endometrium, and she treats women at all stages of their disease course. In addition to her clinical responsibilities, she's lead for undergraduate oncology teaching at Edinburgh Medical School, and she's also a very strong advocate for postgraduate training and specialty training word progress education. So, as I said, we're very happy to have Alison give us a talk today on the management of locally advanced and metastatic endometrial and cervix cancer. Over to you.
So I am a clinical oncologist, and if Karim had asked me to do this talk a few years ago, I don't think I'd have had very much to say, but things have changed significantly in endometrial cancer in the last few years. So let me just, so these are my disclosures. This is a picture of sunny Edinburgh to entice you all to come up north after your training and come with and work with us up in this lovely department. So the objectives of this evening are really to discuss the evolving management of advanced, recurrent and metastatic endometrial and cervical cancer. There's been significant advances in how we treat endometrial and to a lesser extent cervical cancer over the last few years. And I'm going to be limited into how much detail I can go into during this brief presentation, but I've included references to all the papers that are really practice changing to allow you time to read them in more detail at a later date. And I'm going to give a very brief background on endometrial cancer and molecular classification, because I know that many of you won't be involved in treating endometrial cancer. And there's been really significant changes in how we classify endometrial cancer in the last few years. So be aware that it's a very common malignancy of an instance with about 13.6 per 100,000 and rising. The median age at diagnosis is 63 years, but I'm increasingly in my practice seeing women in their 30s and 40s diagnosed with endometrial cancer due to obesity. And as obesity is such a major risk factor, the risk factors are more prevalent in middle and high income countries. The majority of cases are sporadic, but you'll be aware there's an association with Lynch syndrome, and it's estimated to affect about 1 in 300 people. It's an autosomal dominant inherited disorder associated with a high lifetime risk of both endometrial and colorectal cancer, and it's characterized by germline mutations in the mismatched repair genes. The mismatched repair genes recognize and repair errors that occur during DNA replication, and impairments in this pathway lead to germline mutations. And we now test all patients for mismatched repair deficiency in endometrial cancer. Now, I've included a link at the bottom of this slide to the updated 2023 FIGO staging of endometrial cancer, which some of you may be aware of. There's a lot of proponents and opponents of this new system. Proponents of the new system comment that this new staging acknowledges that endometrial cancer is not a single disease entity, but the opponents say that it's complicated and therefore won't be quickly adopted. So I think the jury's still out on it, but it really is worth a read because it helps stratify patients into risk groups. In recent years, there's been a significant change in how we characterize endometrial cancer, and this ultimately is going to impact on treatment decisions and how we design trials going forward. So, when I first started, it was very much characterized as type 1 and type 2. So type 1 were the sort of endometrioid adenocarcinomas, they're all grouped together. And type 2 encompassed all the subtypes, including high-grade serous, clear cell, carcinosarcomas. And additional factors were taken into account, such as the grade, the stage, the presence or absence of lymphovascular space invasion. But more recently, we've had a focus on looking at prognosis and treatment stratification related to molecular classification, because this binary type 1 and type 2 classification is deemed too broad and doesn't really take into account molecular subtypes that have been demonstrated to influence prognosis and really how we treat patients. So the new classification divides the tumours into 4 molecular subtypes, and these are all from the Tumour Cancer Genome Atlas. So we can see here the ones with excellent prognosis are the POLE-E or the ultramutated, moving down into MSI high or hypermutated, copylumbar low and copy number high, and these tend to be the serous-like cancers with a high burden of p53 mutations. And other mutations such as BRCA mutations are being investigated as well. So I wanted to sort of think about where we are. We're really in a crossover from the past, the current, the future, and where are we now? So I'm going to go talk about the standard of care, which probably was a case about a year ago, 18 months ago, for all patients with endometrial cancer. So the standard of care for first-line management was combination chemotherapy, and that's been carboplatin and paclitaxel for as long as I've been a consultant for the last 15 years, and it's been validated in clinical trials. So the GOG 0209 trial was a large phase 3 randomized non-inferiority trial looking at patients with advanced or recurrent endometrial cancer, performance data 0 to 2. And that randomized patients to triplet chemotherapy with doxorubicin, cisplatin, and paclitaxel versus paclitaxel and carboplatin every 21 days, with a primary endpoint of overall survival, and toxicity and health-related quality of life were secondary endpoints. And it confirmed non-inferiority of the doublet combination, with a small health-related quality of life favouring carboplatin and paclitaxel, and not surprisingly, more grade 3 toxicities in the triplet group. So that's what we've been using for the best part of probably 15 or more years in endometrial cancer. And what happened when patients progressed after this treatment? Well, our options were very, very limited. There's no real standard of care in second-line treatment, as depicted in this table. The performance, progression-free survival and overall survival are very poor across a range of treatment regimens and haven't really changed in the time that I've been a consultant. And we know that real-world evidence reflects this poor outcome seen in second-line treatment, with a median overall survival of 10.3 months, with progression-free survival of 7.7 months. So where are we now? Well, thankfully, things have changed a little bit. As you'll be aware from many other tumour types, the PD-L1 pathway represents an adaptive immune resistance mechanism exerted by tumour cells in response to endogenous immune anti-tumour activity. So we're able to harness that in treating a large number of cancer types, such as renal cell cancer, melanoma. But there's been some advances in immune checkpoint inhibitors in the management of endometrial patients. What I would say is it's not for all patients. You know, our patients are comorbid, and many of them would be best treated perhaps with progesterone therapy, etc. And I think it is important that patient selection is at the forefront of who we treat with immune checkpoint inhibitors. And patient education and education of the multidisciplinary team is really important as well. So first-line treatment options now in endometrial cancer, and it's slightly confusing to me because we've had approval for immune checkpoint inhibitors in the second-line setting longer than the first-line setting, but I think it makes more sense for the flow of this talk to talk about first-line treatment options first of all. So not all of these are SMC or NICE approved, and I'll make that quite clear as I go through the talk, if that's okay. So in the first-line setting, there's been a trial of pembrolizumab in combination with cisplatin chemotherapy. And again, the link to the full text is here. It's been published in the New England Journal of Medicine. So this is a phase 3 double-blind randomized placebo-controlled trial, the NRG GY 018 trial. And it's aimed really to evaluate whether the addition of pembrolizumab to standard chemotherapy with carboplatin and paclitaxel was beneficial. And you can see here, over 1,000 patients were enrolled in the trial. 816 patients were included in the trial, 248 were excluded, and just over 200 of them had MMR deficiency, whereas the rest were MMR proficient, which is what we'd expect. It's probably about 25% of all patients with endometrial cancer are MMR deficient. The table shows quite clearly about the patients who were randomized and what they were randomized to, and which patients were included. And you can see from this table here that the clinical and pathological features were well balanced between groups in both the pembrolizumab and placebo arm and the MMR deficient and MMR proficient cohorts. So in terms of the results in the trial, the 12-month analysis here in the MMR deficient cohort, the risk of disease progression or death was 70% lower with pembrolizumab than with placebo. So and that's not quite, the median progression-free survival is not yet reached in that arm. Whereas in the MMR proficient cohort, a median follow-up of 7.9 months, the median progression-free survival was 13.1 months with pembrolizumab and 8.7 months with placebo. I think one of the biggest critiques of this trial is that the duration of follow-up was very short. And I think the other question that needs to be addressed is whether pembrolizumab monotherapy is effective, or whether we need to conclude the chemotherapy, and there's trials looking at that. But it's out with the scope of the time that I have this evening to go into that in more detail. So pembrolizumab in combination with chemotherapy has been shown to be efficacious. It is not currently gone through NICE or SMC, and when I looked in the Cancer Drug Fund earlier this week, I'm not aware that that's available yet, but it's something that is being investigated. But we can see here the benefit, it seems to be greater in the MMR deficient group, which is not surprising. But what about other drugs that have been approved? So dostarlimab in combination with platinum-based chemotherapy has been approved both by the SMC and NICE for first-line treatment of patients with MMR deficient disease. And the New England Journal paper is cited here that you can have a look at in more detail. This the Ruby trial was presented as a plenary session at ESMO last year in October, and it investigated the combination of dostarlimab with carboplatin and paclitaxel first line of patients with primary advanced stage 3 or stage 4 endometrial cancer or first recurrence. And I think it's very important to talk about primary advanced stage 3 disease. So that's disease that we think is inoperable or inoperable at the time of disease. So they've not had surgery, or they've had residual disease after surgery. And I've given you the link to the paper. The primary endpoints were progression-free survival amongst the MMR deficient cohort and the overall patient population and overall survival. So 607 patients were assessed for eligibility, of which 494 underwent randomization, and the equal split between those to receive dostarlimab or those to receive placebo plus chemotherapy. So here you can see of the overall population, progression-free survival in the dostarlimab group versus placebo group, sorry. So 36.1% of patients at 24 months exhibited progression-free survival in the dostarlimab group compared to 18.1% of patients in the placebo group. And in terms of the MMR deficient population, that rate was higher. It was 61.4% had progression-free survival at 24 months versus 15.7% of patients in the placebo group. And this is looking at overall survival in the overall population. So it was 71.3% of patients were alive at 24 months in the dostarlimab group versus 56% of patients, and in the MMR deficient cohort of the population, 83.3% of patients were alive at 2 years versus 58.7% in the placebo group. And this is patients' first-line treatment for advanced or metastatic disease. So we can see a benefit with the dostarlimab regimen in both groups, but the magnitude of benefit is greater in the MMR deficient group. And it was observed consistently with respect to progression-free survival and overall survival based on the pre-specified analysis. There were higher, as you'd expect, higher side effects, but that's consistent with the known adverse events of dostarlimab and chemotherapy. But this clinic, the investigators state that it was well tolerated with relatively low dropout from the trial, and this is now accepted for use in the UK, and it's now sort of standard line, first line treatment for patients with locally advanced stage 3 disease, stage 4 disease at presentation, or first relapse in patients who are MMR deficient. And certainly my experience of it is that it is a well tolerated, generally speaking, treatment for patients of PS0, PS1. So I think patient selection is key. There are patients in whom this would not be appropriate, and we might need to think about alternative treatments as we would normally, such as palliative radiotherapy, progestogen therapy. But for those patients who can tolerate it, it is showing a significant clinically meaningful benefit in terms of progression-free survival and overall survival. There's an additional part to this trial, the Ruby Part 2, which is investigating the addition of niraparib. But again, for time constraints, I haven't gone into that today. But I think hopefully you'll get from this talk that, endometrial cancer, very little has happened in the last 10 to 15 years, and suddenly there's an explosion of treatments, and it's finding the right treatment for the right patient. So what about second line treatment options? So we've had second line treatment options for longer, and that's what kind of threw me when I was positioning this, but I think it makes more sense to talk about first line before second line. So dostarlimab in the second line setting, I've given you a link to the full paper here. So Garnet was a multi-center open label single arm phase 1 study of lots of patients, and not just with endometrial cancer, but for the purpose of today, I'm going to talk about cohort A1. So that is the cohort of patients with MMR deficient endometrial cancer who were recruited into this trial and received dostarlimab monotherapy. So they received 500 milligrams intravenously every 3 weeks for the first 4 cycles, and then switched to 1,000 milligrams every 6 weeks until disease progression, discontinuation, or patient withdrawal. And the primary endpoints in this trial were overall response rate and duration of response by blinded independent central review using RECIST criteria. And secondary endpoints included progression-free survival and overall survival. What we'd say is this trial did include carcinosarcomas, which are a rare subtype of endometrial cancer, which have been excluded from many trials in the past, but the patient numbers were low. So you can see here the demographics and baseline characteristics. So the median age in the trial was 65, which would be anticipated, and you can see the prior lines of treatment. So all patients had had previous treatment. Some had only had previous treatment in the adjuvant or neoadjuvant setting, and about 70% of patients had prior radiotherapy. So some of these patients had were having treatment for, they were having treatment for relapse disease who may have had locally advanced disease or relapse disease in previous settings. And the majority of patients had had 1 line of therapy, but about 25% had had 2 prior lines of therapy. And you can see the majority of them were grade 1 or grade 2 endometrioid adenocarcinomas, with a much smaller proportion of serous or carcinosarcomas, which would fit with the MMR deficient population of this patient cohort. And this is just looking at the outcome of patients. So it's looking at the estimated probability of response. So you can see here in this paper shows both the MMR deficient and MMR proficient group. The top slide here shows the estimated probability of response at 12 months in MMR deficient patients of 93.3% and at 24 months of 83.7%. And what this slide does here is that showing that responders were seen across all histological subtypes. There's quite a lot of information on this slide, but you might want to go back and look at it. But it's showing the cancers, the grade 1, grade 2 cancers, the unspecified cancers, mixed carcinomas, serous cancers. And what it's showing is you can see the ongoing response and duration of response among those who are responding. And the figures show the time since initiation and those still on treatment. So you can see patients are responding right up to, some patients are responding right up to over 120 weeks. So the key points really are here is that dostarlimab has demonstrated durable anti-tumor activity in the MMR deficient population of advanced and recurrent endometrial cancer. The safety profile was generally manageable. The majority of treatment-related adverse events were grade 1 or grade 2. We saw quite a high proportion of patients with thyroid dysfunction, which I think we're becoming, very comfortable with managing. Very low rates of pneumonitis and colitis, and discontinuation rates were low. So we're now in a position to be able to offer this to patients in the second line setting. So patients who have not been exposed to prior IO therapy, who may have had carboplatin, paclitaxel in the first line setting, we're now able to offer this monotherapy in the second line setting. And certainly we've got quite a few patients on the treatment responding well and seeing really good responses. And that's for patients who are MMR deficient. So another trial here published in the New England Journal of Medicine looked at pembrolizumab and lenvatinib, an oral tyrosine kinase inhibitor, in patients with advanced recurrent endometrial cancer. So the Keynote 775 trial was a phase 3 trial aimed at confirming the results of an earlier phase 1b and phase 2 trial. And eligible patients were randomized to pembrolizumab 200 milligrams intravenously 3 weekly with oral lenvatinib or daily, or the investigator's choice of chemotherapy. So that was either weekly paclitaxel or doxorubicin, and treatment was continued until disease progression or unacceptable toxicity. But clearly doxorubicin was capped at maximum cumulative dose of 500 milligrams per meter squared. And they were randomized to treatment group according to MMR status. And the primary endpoints were overall response rate and duration of response. And you can see here the patient demographics in the lenvatinib pembrolizumab arm and the chemotherapy arm, and they were well matched. And again, the MMR status, the proportion of MMR deficient patients was equivalent in each arm, as it was performance status and history of prior pelvic irradiation. And this graph here depicts the progression-free survival in the overall trial population and the MMR proficient population. So it's slightly confusing the way the different trials report. So this trial here looked at all patients and then specifically MMR proficient patients. So you can see here in the top of the diagram, the median progression-free survival was 6.6 months in the lenvatinib pembrolizumab arm versus 3.8 months in the chemotherapy arm. And in all comers, so including the MMR deficient population, it was 7.2 months versus 3.8 months. So you have to bear in mind that these are patients who have had been previously treated. And in terms of overall survival, in the overall trial population, the overall survival was 18.3 months versus 11.4 months. And in the MMR proficient population, it was 17.4 months versus 12 months. So a clinically meaningful improvement in overall survival in pre-treated patients. And I think the adverse events were manageable. There were issues with hypertension from the TKIs, issues with immune checkpoint related toxicities. Stomatitis is another side effect that I've seen in patients, but quality of life was acceptable. In terms of limitations of this study, in terms of duration of follow-up, but the current positioning in the UK practice is lenvatinib and pembrolizumab are approved for second-line treatment of patients who have received prior systemic therapy for locally advanced or metastatic endometrial cancer. And it's another treatment option for us. So I think the SMC approved it for all patients irrespective of MMR status, whereas dostarlimab is only approved for patients with MMR deficient disease. So in terms of current positioning of management of endometrial cancer in the UK, I think for second line, we have the option of dostarlimab monotherapy or pembrolizumab and lenvatinib combination therapy for patients. First line, we have the option of dostarlimab in combination with platinum combination therapy for patients who have MMR deficient disease. I may be wrong, but I'm not aware that pembrolizumab is available in the Cancer Drug Fund in the first line setting, and certainly is not available in Scotland. In terms of clinical trials, there are quite a few clinical trials open, and you may have access to them in your centres. There is the ATARI study, which is an ATR inhibitor in combination with durvalumab plus or minus a PARP inhibitor in patients who've progressed having previous immune checkpoint inhibitor therapy. There is the Domenica study, which is a first-line study that is already open in France, and we're just hopefully going to get it up and running in our centre shortly. And that's looking at dostarlimab versus chemotherapy in the first-line setting. And there's been some people who said that'll be quite challenging to get patients into that study when you've already got access to dostarlimab plus chemotherapy. But I guess the question is, do we need to have the chemotherapy in that arm? And there will be eligibility to cross over in patients who are assigned to the chemotherapy arm should they develop progressive disease. So I think we need to see how we manage to randomize patients into that trial. And also the Rodeo study, which is looking at neoadjuvant dostarlimab in patients with locally advanced MMR deficient cancer as well. And there will be other trials, smaller trials open up in other centres. So I think it is an incredibly exciting time for managing endometrial cancer. I was very lucky to get to ASCO a few weeks ago, and there's just so much out there that I don't have time to talk about today in endometrial cancer, because I also need to talk about cervical cancer. But there's been phase 2 studies of fulvestrant and abemaciclib in hormone receptor positive advanced or recurrent endometrial cancer, and that might be something we might consider in patients in whom who have other comorbidities and in whom the immune checkpoint inhibitors might be more challenging to manage. We used to using CDK4/6 inhibitors in patients with breast cancer or PS2, for instance, whereas all the trials of immune checkpoint inhibitors have been in patients with PS0, PS1. There's the GOE trial, which has looked at durvalumab plus chemotherapy followed by maintenance durvalumab with without olaparib as first-line treatment for advanced endometrial cancer. And there's been another trial looking at selinexor in patients with advanced or recurrent endometrial cancer. So there's so much going on in endometrial cancer that if you'd asked me this 3 years ago, I'd have laughed at the thought of being able to talk for more than 2 minutes about endometrial cancer. So that's a really brief overview. I apologize just in the constraints of time, but I have given you links to all the papers there if you want to look at things in more detail. But you need to watch this space because things are changing on a monthly basis. As most of you are probably medical oncology trainees, I imagine your exposure to cervical cancer patients is probably quite limited. I guess some of you may be involved with the metastatic management of endometrial cancer, but cervical patients, I imagine you are quite limited. So with early stage and locally advanced disease, we can treat it very well with chemoradiotherapy and cervical brachytherapy, but very limited treatment options for patients with persistent, recurrent, or metastatic disease. Oligometastatic disease can be amenable to localized treatments such as exenturative surgery, stereotactic radiotherapy, but prognosis for patients with metastatic disease is poor. The standard treatment for this patient group is combination chemotherapy plus or minus bevacizumab, and it's now been 10 years since the trial of chemotherapy in combination with bevacizumab was published, which showed a significant improvement in overall survival in patients of more than 3 months, and particularly given that this patient group spans patients in their 20s right up to their 80s. It was a significant game changer. And then not much happened until more recent trial of Keynote 826, which was a randomized double-blinded placebo-controlled trial of chemotherapy plus or minus bevacizumab in combination with pembrolizumab. And it really built on an earlier phase 1b trial that showed there was safety and efficacy in this treatment population. So this is just the trial schema here. And patients were randomized to placebo or pembrolizumab in combination with chemotherapy plus or minus bevacizumab. And some patients who may choose to avoid bevacizumab due to disease features, recent radiotherapy, etc. And patients continued on treatment until disease progression or unacceptable toxicity. And again, I've included the link to the full paper there for you. And patients in this trial were stratified depending on their PD-L1 combined positive score, whether they had metastatic disease at the time of diagnosis, and whether an intention was to treat them with concurrent bevacizumab. And it had dual primary endpoints of overall survival and progression-free survival. And you can see here in patients with a CPS score of greater than 1, the 12-month rate of overall survival was 75.5% in the treatment arm, the trial arm, and 63% in the placebo arm. And at 24 months, 53.5% of patients were still alive in the pembrolizumab arm compared to 39.4% in the placebo arm. And what I would say is the median age of patients enrolled in this trial was 51. So the range of ages was from 25 to 82, which reflects clinical practice and the wide range of age of patients that I see here. And you can see a significant improvement in survival in the pembrolizumab arm. And again, even with progression-free survival, a significant improvement. And the median duration of response is higher in the pembrolizumab combination. In terms of side effects, the pembrolizumab inclusion with chemotherapy didn't exacerbate the known toxic side effects of chemotherapy. And of the immune-mediated side effects, most common, which we commonly see, is thyroid dysfunction. Very few patients had colitis and pneumonitis. And I've just recently audited our patients. We've got about 20 patients that have had this regimen since it's been approved or before approval in sort of a patient access scheme. I've had only one patient with a delayed nephritis at 10 months, and as yet, touch wood, no colitis or pneumonitis in the patient population. I think what we do see is some atypical responses or pseudoprogression in this patient population. So we do really need to hold our nerve when we're treating the patients. So what we'd say is the addition of pembrolizumab has shown a clinically meaningful improvement in progression-free survival and overall survival in patients with PD-L1 CPS score of greater than 1. And it now really is the standard of care for appropriate patients across the UK. What about locally advanced disease? In the last few minutes, I want to talk about locally advanced disease. There's been a lot of trials. There's been the Outback trial, the Interlace trial, and the Keynote A18 trial. So I'll just very briefly give a summary of those. And again, I've given the whole text links there. So the Outback trial was by a colleague I worked with when I did my fellowship out in Australia. So Linda Malishkin ran this trial of over almost 1,000 patients with locally advanced cervical cancer treated with concurrent chemoradiotherapy with curative intent. And this trial was looking at the addition of adjuvant chemotherapy on completion to see if it improved outcome in terms of survival. And at 5 years, there was no significant increase in survival in patients who received the adjuvant chemotherapy, and patterns of disease recurrence were similar. So this trial has not shown out adjuvant chemotherapy to be, practice changing in locally advanced cervical cancer. Interlace was an oral presentation at ESMO last year. It has not yet been published in paper, but what this showed was induction chemotherapy with weekly chemotherapy prior to concurrent chemoradiotherapy improved outcome in patients. Now, there's obviously opponents and proponents of this trial, and the trial did take quite a long time to accrue, over which time radiotherapy techniques have changed considerably. We're now using volumetric therapy for all VMAT therapy for all patients with cervical cancer. We're boosting large lymph nodes with simultaneous integrated boosts, and we're using image-guided brachytherapy. So there has been a change of radiotherapy in that time. So not all centres have integrated the Interlace protocol yet into their standard treatment arm. I guess many places are waiting for the paper to be published. The last thing I want to talk about is the Keynote A118 trial, and that's been published in the Lancet, and that is a trial of concurrent chemoradiotherapy with pembrolizumab in patients with locally advanced cervical cancer, and looking at the efficacy and safety of adding that in the locally advanced patient group. And what that trial has shown is improved progression-free survival in patients with high-risk locally advanced cervical cancer. It has been FDA and EMA approved, but as yet has not been approved for use in, it hasn't been sort of submitted to NICE or SMC. So I'm sorry, that was a really fast run through of everything that's been happening in endometrial cancer. And I apologise, I've not gone into the trials in significant depth, but it should really just give you a bit of a flavour of what we're doing in endometrial cancer now and what might happen in the coming months and years.
Great, thank you so much, Dr. Stllie. That was an absolutely fantastic whistle-stop tour. I know, I don't know if anyone else is sitting the SE in a couple of months, but that was really, really useful going through all the key landmark trials. So thank you again. There are a few questions trickling through the chat. If anyone would like to ask a question for discussion at the end, please do post. It's my pleasure to now introduce Dr. Axel Walther, who is a colleague, consultant medical oncologist at the Bristol Cancer Institute, working across both Bristol and Western. He's also the gynae-oncology lead and treats all gynecological malignancies, but of course, practice is significantly dominated by patients with ovarian cancer, I think is fair to say. So he's going to talk to us about the complicated paradigm that is maintenance therapies in ovarian cancer. I know this is something that trainees find quite daunting, so hopefully this is really useful for everybody. Over to you, Dr. Walther.
So thank you very much, Ella, for that introduction, and thank you very much for having me. I can't promise you that it'll be clearer after my talk, but at least I will hopefully, like Alison has just summarized some of the key studies, I will also have done that for you. And again, all my slides have the references, sort of slightly abbreviated form at the bottom, but just so that you also have access to that. So I'm going to focus on the maintenance strategies in ovarian cancer. And with that, what we will talk about is bevacizumab, PARP inhibitor, and combination. I will not cover primary treatment strategies or choice of chemo at recurrence. That is a much longer talk. So if we dive straight in, when I became a consultant some years ago, so there was actually no maintenance, and bevacizumab was just coming through at that point, and everybody was marginally excited. I mean, I think bevacizumab is one of those drugs that actually every trial you look at, it has a little bit of benefit, but it's not groundbreaking in the way that other drugs that have come out since have been. But bevacizumab has nonetheless found its way into the management of many cancers, including ovarian cancer. So initially, we were all quite excited about the ICON 7 and also the GOG 218 study, which I'm going to show you in a second. There were trials in patients predominantly with advanced disease, although the ICON 7 study had some earlier stage patients as well, who got primary surgery, then adjuvant chemotherapy on its own with bevacizumab, and then stop after 6 cycles, or chemotherapy with bevacizumab and then maintenance bevacizumab in the ICON 7 study for up to 18 doses, so 12 after the chemotherapy. And as you can see here, that was the primary progression-free survival analysis. There was a benefit of having received bevacizumab, the red line, or magenta, whatever it is, at the top, showing you that at the end of the treatment, which is in the dashed line, there was a clear benefit to having had bevacizumab, but that benefit eroded over time. And there was a lot of soul searching done, and that's where this trial has given us the restricted means analysis as a way of comparing trial outcomes rather than just hazard ratios, because hazard ratios require you the hazards indeed to be proportional over time. So clearly, the relative distance between the top and the bottom line needs to be the same, which isn't the case here. But even with a restricted means analysis, this came out as statistically significantly better. But they then also went one step further and said, well, are there subgroups we can define that perhaps do better versus others? And the ICON 7 trial then defined the high-risk group of patients with stage 4 disease or diagnosis, or those who had a residual disease at the end of their surgery. So stage 3 disease with residual, microscopic residual disease, so suboptimally debulked. Versus those patients who had stage 3 disease with complete debulking surgery or earlier stage disease, although that was only about 10% of the trial population. And you can see that the top 2 lines, there is no difference for the low-risk group, but actually there's a clear benefit for the high-risk group, which is with a statistically significant hazard ratio, but also more importantly, a clinically meaningful benefit. If you look at the G218 study, which is the American study, they had exactly the same trial design. The only thing that they did different was that they had all advanced disease, and they gave the bevacizumab maintenance for slightly longer than we did in Europe, for up to 15 months of treatment. But because they included the time on chemotherapy in this assessment as well, as in the 50 months period, it was roughly 10 months after the completion of chemotherapy. And that they didn't show any difference. This slide is only to show you in the exploratory stage 4 analysis, analysis of stage 4 patients. You can see that there seems to be a benefit of the top thick blue line of patients who got maintenance chemotherapy over the other 2 groups. And much as this was exploratory and they didn't give you a p-value, I've taken the liberty of calculating one that to be taken with a pinch of salt. But it's in the sort of standard view of the world, this would be a statistically significant finding, and certainly had it been a pre-specified analysis. Again, the dotted line gives you the end of treatment, and there seems to be a benefit that persists over time. So I think it is fair to say, out of these studies, bevacizumab got established certainly for all patients with high-risk disease, either stage 4 or the suboptimal about stage 3. But it has a license for all patients with stage 3 and stage 4 disease. And that is going to come back to bite us in the bums a little later when we look at the Paolo study, but which I won't cover at this point, but chuck that in with the PARP inhibitors later. But certainly, in the UK, well, I say the UK, in England, you can have bevacizumab on the ICON 7 schedule for 18 doses of bevacizumab, which includes those doses you might give with chemotherapy in patients with a high-risk definition as defined by ICON 7. I believe in Scotland that's the same, although you also have the advantage of being able to use it in the platinum-resistant disease. Again, that is not something I'm going to cover today, but there is some evidence to say that re-challenge with bevacizumab after initial bevacizumab actually retains additional efficacy. If you look at the AGO OVAR 17 boost trial, if you think back to the curves of the ICON 7 trial that I showed you that had sort of drifted apart and where the maximal separation was at the end of the bevacizumab maintenance, and then the curves came to get together again, there was a reasonable thought at the time that what if we treat longer? So this trial was exactly the same, first-line patients with stage 3, stage 4 disease, stratified by low and high risk groups along the ICON 7 definitions, and randomized to either 15 months of bevacizumab or 30 months of bevacizumab. And as you can see, there is absolutely no difference at all between those groups. So there seems to be a benefit early on. There seems to be some benefit in terms of overall survival for the high-risk groups, but there doesn't seem to be any additional benefit if you continue longer. And I think that to a degree that probably tallies with clinical practice, in that most patients with high-risk disease, and certainly those who still get bevacizumab at this point, progress just before or shortly after the end of their maintenance therapy. And so actually the additional length of treatment that might be available, I don't think is particularly relevant anymore either. But there's now data to say that probably it's not worth your while either. And then we have ICON 8B, which isn't technically a maintenance study. It was a study of how do you treat first-line disease. And the only reason for chucking it in here is because they did have carboplatin, paclitaxel, bevacizumab on the traditional 3-weekly schedule along the lines of ICON 7 versus carboplatin, weekly paclitaxel together with bevacizumab. Again, the bevacizumab schedule as per ICON 7. The only difference between those two arms is that you have weekly paclitaxel in the arm B3, the green one. And there's clearly a benefit over time. This has only been presented so far at SGO last year and hasn't yet been published. So we do need to get our teeth into this a little bit. But there is most of those patients who are stage 3 or stage 4 disease, stage 3C or stage 4 disease, and the vast majority, 85% or so, had interval debulking surgery. And that is relevant, of course, if you think about whether bevacizumab prior to surgery is safe or not. In our experience in Bristol, we've had some unpleasant surgical complications in patients who had pre-operative bevacizumab, and that isn't to say that this necessarily it was linked to the bevacizumab, but on the basis of the ICON 7 and to a degree GOG to 18 study, the benefit seems to be very much in the maintenance rather than giving it with chemotherapy. And my personal view is to start bevacizumab after surgery and not give it before. The ICON 8B study suggests you get slightly higher rates of complete debulking surgery if you give bevacizumab prior to surgery, but you also get higher rates of you get about 8% rate of fistulation. And I think that the benefit of achieving surgery getting patients to surgery outweighs the slightly increased chance of getting a complete versus optimal debulking surgery. But we'll wait for the final publication of this so that we can get our teeth into this. And I obviously reserve the right to change my mind if new evidence becomes available. Right. Sorry, there was changing tack slightly. And as Alison has gone through the uterine cancers and their molecular classification, of course, we have a molecular classification of ovarian cancer now as well. And the important thing to say about this is, of course, there are other subtypes of ovarian cancer other than high-grade serous. A lot of the bevacizumab work has actually been done in all ovarian cancers, so high-grade serous, and that's a dominant subtype in all of those trials. But endometrioid, clear cells, and to a degree low-grade cancers were also permitted at the time in a way that they weren't in the PARP inhibitor trials. So high-grade serous carcinoma, the commonest subtype, about 70%, is characterized by a near ubiquitous mutation in p53, and about half the patients have homologous repair deficiency, which is BRCA mutations either through the germline or acquired in the tumor, and then a whole host of other things listed there, ATR, ATM, RAD51C, the Fanconi genes, P10, etc., etc., etc. And we currently don't have a very good test for all of those alterations, and which is why we have the homologous repair deficiency and proficiency score, initially the genome instability score by Myriad, and now the genome instability index that the NHS has developed to try and separate the HR proficient from the HR deficient patients. And I come back to why it matters that this test isn't perfect, because it might explain something that we see about the data. A brief other note on the molecular subtypes. We used to think that low-grade serous carcinomas were sort of a part of the progression to high-grade serous, so borderline serous, low-grade serous, high-grade serous. I think the genetic mutational landscape is so different in the low-grade serous cancers that is now gone out of the window, because you would have to postulate that you have lots and lots of mutations that all revert to then give you new mutations. And whilst theoretically, BRCA mutation could outweigh the benefit you get from a mutant BRAF, and therefore you have a reversion mutation, is quite complex, and I suspect is not what happens in real life. What does PARP do? PARP is part of the basic excision pathway. So if you have a single strand break, that gets highlighted by the PAR, the poly ADP ribose polymerase, which sticks a PAR flag onto that site, which then acts as a signal for the basic excision and single strand repair machinery to come along. The PAR flag gets removed and recycled, and the single strand break repaired. So if you have single strand break deficiency and you have double strand break deficiency, the cancer can't cope. That sort of mechanism is called synthetic lethality. So the cell can cope with either having an abnormality in homologous repair deficiency, which is a double strand break, as well as single strand breaks repair deficiency, but it can't tolerate both. So if you have a single strand break in the presence of a PARP inhibitor, that gets converted into a double strand break, and homologous repair is very efficient at repairing this, and the cell can survive. If you have a BRCA mutated cell, or indeed a cell that is homologous repair deficient for other reasons, that cannot repair this double strand break efficiently. And whilst there is non-homologous end joining, as soon as you have double strand breaks, your chance of using non-homologous end joining to get the correct repair is 1 in 2. And if you have 10 breaks, then you have a 1 in 1,000 chance of getting all of them right. So suddenly this is very inefficient, and it's just an emergency way of sticking DNA together, but it's not sensible for highly evolved cells to survive an onslaught of many double strand breaks. On the other hand, if you have a single strand break, and if you do not have a PARP inhibitor, then that just gets repaired by the single strand break machinery. So either of those two deficiencies tolerated by the cell and it's consistent with cell survival. If you have both, then the cell dies, and that is called synthetic lethality. So the original study was of PARP inhibitors was olaparib in study 19. This was all relapsed patients, and they weren't stratified by BRCA mutations or indeed homologous repair deficiency, and this clearly showed a benefit for olaparib over placebo. This is brilliant, led to the approval of olaparib in BRCA mutated patients, because at the time we didn't have a good test to test patients who were non-BRCA mutant but also had homologous repair deficiency, and which slightly slapped the label of the BRCA mutant patients onto olaparib, and they've struggled. Olaparib has struggled ever since to shake that, to say that actually it might work in other cancers, as in homologous repair deficient cancers in particular as well, in a way that both rucaparib and niraparib have license for that. And I will just show you some data, comparative data. As always, don't compare across trials, although much as it is statistically permissible, if the trials aren't in the same patient population, with the same age distribution, with the same pathological distribution, with the same primary treatment, with all those variables that might be different, but theoretically, if all those variables are the same, then you can make some assessment across trials. That's not the exam answer, that's a sort of the postgraduate answer. But this is just to suggest to you that perhaps there isn't a huge amount of difference in second-line patients. So this is the data in the second-line setting, the only place where we have good data for BRCA mutant patients that you can compare, and there really isn't much difference between those curves. I'm not saying there aren't subtle differences, but on the back of this data, I would be very comfortable if the NHS decided that we were only ever allowed to use one PARP inhibitor. I'd rather use that if that allows me to use other clever drugs than fight over one versus the other. And PARP inhibitors also benefit all subgroups. So when I think subgroups, I say BRCA mutant, HR deficient without BRCA mutation, and HR proficient. And so both rucaparib as well as niraparib, and this is the niraparib data, the second line study, the NOVA study showed that there was clearly a benefit of niraparib over placebo in BRCA mutant patients on the left. That is what you would expect. The middle graphic is in HR deficient patients without a BRCA mutation, and so you get a slightly less marked benefit, but you still get a very big benefit. And then in the HR proficient patient, the benefit is much smaller, although technically, if you look at the hazard ratio, so the relative benefit is just as big in the HR proficient patient as it is in the other subgroups. But the absolute benefit is much smaller. Second line data. So the question is, why is that? And that comes back to the test we have for HR deficiency. If the test is perfect, then there's clearly something about the biology and pharmacology of PARP inhibitors that we don't understand, because it shouldn't work in HR proficient patients. Or our concept of synthetic lethality is wrong. But there's some fundamental thing that we don't understand. But it is just possible, and I'm not suggesting that that's the cause, but it is just possible that the test that we have misallocates some patients that are HR proficient to the HR deficient group and vice versa, which is why you get slightly less benefit in the HR deficient group, because you are being dragged down by the few HR proficient patient, and the HR proficient patient gets some benefit because actually you have some HR deficient patient misallocated, and therefore they would benefit from the niraparib treatment. I don't know the answer to this question. I think until we do, I'm very comfortable of using niraparib even in HR proficient patient, because if there is a benefit, even if it is a small benefit, often these are patients with relatively poor prognosis. I'm very keen that they shouldn't miss out. That doesn't mean to say that if they do then run into toxicity problems, and niraparib in particular has got a lot of myelotoxicity, then there's also a relatively lower threshold for stopping in those patients. If we now move to the first line, so this is the second line data, and clearly PARP inhibitors are useful in the second line, and I will come back to where they sort of sit in first line, second line in a minute, but I will show you the first line data. And so this is Solo 1, done with olaparib tablets in the first line setting. And the reason this is only BRCA mutant patients, the reason why olaparib has been stuck with a BRCA mutant label is because a study from 2019 showed that it was the only license they got out of that was BRCA mutant patients, but not anyone else, partly because there wasn't a good test for it. Back then it was capsules, which were 8 twice a day. And then niraparib came along, which was 3 tablets a day, and AstraZeneca felt that they really couldn't put their patients through 8 BD, and so they tried to convert that to tablets and thought we'd do a quick phase 1 and have a biologically equivalent dose, and that didn't work. That phase 1 trial took 2.5 years, and at the end of it, the FDA said, we still don't buy that these are equivalent, you need to do another trial. At which point AstraZeneca chose not to do a replica of the NOVA and the Ariel 3 study, so the niraparib and rucaparib trials in the second line, which was all comers, but just focus on the BRCA mutant patients just to get that across the line. Recruited like the clapper Solo 2, and clearly showed that there was a benefit of the tablets as well, just as you would expect. But that then put olaparib into the BRCA mutant bucket. And so Solo 1 again, so the first line study was again first line patients. But what they did get in return was, of course, this spectacular median progression-free survival of 54 months versus 15 months in the placebo group. Hazard ratio of 0.3, and you may note that that hazard ratio actually is very similar to the hazard ratio in the second line that I showed you with niraparib. And it's in, wherever you look, the hazard ratio, so the comparison of the PARP inhibitor arm to the placebo arm, that relative benefit is roughly the same across lines of treatment and across PARP inhibitors, and indeed across molecular subgroups. So they do work and they do add something. But olaparib in the first line, clearly that is a slide that, if you're selling olaparib, is a very easy sell. Do you want your patient to have this spectacular median progression-free survival? And olaparib has now become the go-to drug for BRCA mutant patients in the first line. Much as I don't believe that there's a difference between olaparib and niraparib and rucaparib as and when it becomes licensed in the first line. What if there is something different about olaparib in the first line? 1, and 2, if I can't say that niraparib is definitely better, then why would I choose that over olaparib given this data? So I think olaparib probably has cornered the BRCA mutant first-line market, as it were. PRIMA was the niraparib first-line study, and this looks very much less good. And this is where, of course, you always need to go into the detail of the trial when you're looking at them. This is the sort of headline figures, progression-free survival, but this is all comers. And in fact, PRIMA set out to look for particularly bad prognostic patients. So niraparib and placebo, again, primary chemotherapy, so surgery, primary chemotherapy, and then maintenance with PARP inhibitor. None of these patients had bevacizumab maintenance. And so clearly, niraparib seems to do much less well, but patients were not all BRCA mutant, much higher proportion of stage 4, much higher proportion of suboptimally debulked patients. So if you look at the various features of PRIMA, SOLO-1, PAOLA, which was PAOLA was bevacizumab on olaparib versus bevacizumab alone. And I'll come back to that a little later. And the ICON-7, if you look at the stage 4 residual disease and a partial response to chemo, PRIMA had the highest proportion in each of those categories. Although, to be fair, PAOLA also had a relatively high proportion of stage 4 patients and a relatively high proportion of residual disease, although nowhere near as high as in the PRIMA study. And the reason why that matters is, we'll skip that. The reason why that matters is that if you plot the percentage of stage 4 patients in a trial against the median progression-free survival for the whole cohort in the placebo-only arm, so these are all the arms in various trials where the patients got chemotherapy and surgery, possibly placebo after, but certainly no active treatment, you can see that ICON-7, bevacizumab control arm, SOLO-1, BRCA mutant patients, but placebo control arm, ERTC and CORES were the surgical trials of primary versus interdebulked surgery, and PRIMA being the niraparib trial, that there's a very clear correlation that the more stage 4 patients you have, the less good the outcome in your overall cohort. That's to a degree how stage 4 is defined. But the same holds true for suboptimal debulking surgery. And therefore, having a high proportion of stage 4 and suboptimally debulked patients clearly means that the overall cohort is going to do less well than if you have a lower proportion of that. If we then, we'll skip that for the time being as well. That's the comparison of the first-line trials of olaparib and niraparib. I haven't gone into rucaparib. It's a similar picture to niraparib, but it's not yet funded. It shows similar data. I think in the interest of time, much more interesting is the PAOLA trial. Interesting and frustrating. So if you look, so PAOLA was a study, again, primary debulking surgery and or interdebulking surgery, 6 cycles of platinum-based chemotherapy, followed by maintenance either with bevacizumab or bevacizumab and olaparib, and the patients could start the bevacizumab, well, did start the bevacizumab with their chemotherapy. This is mostly American patients. Most of those had primary, about half of them had primary surgery, but they all would have received bevacizumab before surgery if they had interval debulking surgery. And so top left is patients with a tumor BRCA mutation. There's a clear benefit to olaparib added to bevacizumab. Bottom right is HRD, so homologous repair deficient cancers, but for a reason other than the BRCA mutation. Again, you get a benefit from olaparib over bevacizumab. And the bottom left is patients with homologous repair proficiency, and there was no benefit to the combination. So in principle, of course, olaparib adds to bevacizumab. Clearly, we should use both drugs, right? Well, this is not that straightforward. So there's no benefit to combination therapy in HR proficient patients. So that's the first group that falls out of that assessment. And secondly, in SOLO-1, you get a much higher progression-free survival benefit with BRCA mutant patients than you got on the PAOLA patients. So again, the PAOLA had slightly less good patients, more stage 4, slightly higher proportion of suboptimally debulked patients. But the question really is, and I think most oncologists would think that the trial you really need to do in BRCA mutant patients is not bevacizumab with or without olaparib. I think no one in their right mind, I don't want to be too directive, if you like, but in my mind, you need to give patients with a BRCA mutation a PARP inhibitor. The question is, does adding bevacizumab really get you anything other than toxicity? And that question isn't answered by the PAOLA trial. To a degree, that holds true for homologous repair proficient patients as well, although you can see an argument if the absolute benefit of a PARP inhibitor is less good, maybe bevacizumab adds something. But again, you need to prove that bevacizumab is additive to olaparib, because I would still choose olaparib over bevacizumab if I only could choose one. And the HR proficient patients, clearly olaparib doesn't add to bevacizumab, so you would probably want to give them bevacizumab or indeed niraparib, because you've showed you earlier that that might work. And I had very much made up my mind that I was going to wait for further data to come out. And I think I've forgotten the name of the trial, but there's a trial looking at niraparib and bevacizumab in the first line data in the first line setting, which is a 3-arm study of bev alone, niraparib alone in combination. Hopefully that will answer the question. The one thing that I was ready to completely write it off, I'm now doing something that I told you earlier much is you're not meant to do this. I've superimposed the curves of the SOLO-1 trial onto the PAOLA trial. So the curve in the middle is SOLO-1. The top curve is olaparib plus bevacizumab. The bottom curve is placebo plus bevacizumab. And much as the median progression-free survival in PAOLA is less good than that of SOLO-1, you can see that SOLO-1, the curve hasn't crossed the 50% mark on this particular graphic, and the PAOLA olaparib plus bevacizumab has. The olaparib plus bevacizumab line runs above that of SOLO-1, and if anything, you have a poorer prognostic group in that trial than you do in SOLO-1. Again, you cannot cross-compare trials, but it raises significant doubts that actually, or in my mind, adds to the weight to the argument that actually there may be a synergistic benefit between the two drugs. And I now discuss with patients about adding bevacizumab to olaparib maintenance, even in BRCA mutant patients. We don't always do it. Some patients elect not to have it, but some patients elect to have it. I was rather hoping I wouldn't have to have that discussion with imperfect data, but we are where we are. So what I do is I look at my high-grade serous ovarian cancer. I have BRCA mutant, HR deficient disease, and HR proficient disease in the first two groups. I then, in my mind, split them into low-risk and high-risk groups. And I think for low-risk BRCA mutant patients, I would give olaparib on the basis of the SOLO-1 trial, but niraparib is clearly, I don't think there's anything to choose between them. If patients don't get on with olaparib, and in my hands, I have found that olaparib occasionally can cause really quite a lot of fatigue without anemia. It would be nice if one could switch to niraparib. In the UK, you can't, to the best of my knowledge. As in England, you definitely can't. I don't know about the other countries. But in other jurisdictions, on the continent in the US, that might be an option. I think for patients with high-risk disease, they fit much better into the PRIMA group of high-risk first-line patients with niraparib. That's an option. You could give, in BRCA mutant patients, also olaparib, and you could then consider whether you add bevacizumab to that as well. We don't know whether it adds anything other than toxicity, but wouldn't be unreasonable in that group. In the low-risk group, in the HR deficient patients, olaparib on its own isn't licensed, so that leaves you with niraparib. I don't particularly see the benefit of bevacizumab in that group, and I typically don't use it. In the HR proficient patient, bevacizumab as a first line, because again, in England, you can only use bevacizumab in the first line. If you don't use it, then you've lost it. Those are often patients with poor prognostic disease. So I use bevacizumab in the first line and niraparib in the second line. Whereas for if they're BRCA mutant, I would always use the PARP inhibitor in the first line and be agreeable to forego the bevacizumab if indeed the patient didn't receive it then. And then that leaves the high-risk HR deficient group, and I think that's where the strongest argument is for olaparib bevacizumab in my mind. In the young and fit patients, I wouldn't give this to an older patient, but certainly the young, fit and committed patients, it is reasonable, but likewise so would be niraparib on its own. Right, that is a gallop through my take on maintenance therapies in ovarian cancer. There's a couple of podcasts that one of my colleagues in Bristol has recorded. It's more of my voice, if you can bear that. It's a slightly broader overview over initial treatment of ovarian cancer and then the recurrent treatment. If anyone is interested, tap in and have a listen. It recaps some of the data I've just talked about. It also, goes slightly broader into choice of chemotherapy, timing of surgery, etc., etc., etc. Right, that's it. Thank you.
Great, thank you very much, Axel. That was a very comprehensive overview of all the trial data, including all the nuances in the trial. First question to Dr. Stllie is, what is your opinion of which treatment options to choose between second-line dostarlimab and pembrolizumab?
Right, thank you. I've put my camera on, so if the sound quality dips, I'll switch it off again. I think certainly across colleagues across the UK, I think for MMR deficient patients, the majority of us would use dostarlimab because it's monotherapy. The doublet of pembrolizumab and lenvatinib does have added toxicity, so I would reserve that for MMR proficient patients.
Okay. Axel, you have something to add?
Yes, I think, again, the trial didn't compare len-pem versus pembro alone. You don't know whether lenvatinib adds anything to the pembro in mismatch repair deficient patients. It adds a lot of toxicity, to the point that I haven't yet got a patient who I've managed to keep on the 20 milligrams of lenvatinib. Mismatch repair deficient patients get IO, whereas pembro or dostarlimab, I mean, you take your pick to a degree. I think most of us use dostarlimab.
Okay, thanks. I think that's really clear. Patients with carcinosarcoma, so Dr. Stllie, one of your graphs showed the response rates in a phase 1 study showing that all comers responded, but is dostarlimab available for patients with carcinosarcoma?
So carcinosarcoma patients were included in the trial, but the proportion of them was very, very small because the majority of them aren't MMR deficient. The majority of them have copy number high P53 mutation. It'd be very uncommon for them to be, so there'd be a very small number.
Okay. I know treatment options are certainly more limited for patients with carcinosarcoma, unfortunately. What is your practice? I guess this goes to both of you, in young, fit patients this is cervical cancer patients that have progressed on platinum, Taxol, Bev, and Pembro, if you've used all of your drugs up front.
So I'm in a position that at the moment that I've not yet encountered that. And I think the time is going to come. I've got a lot of patients on almost 2 years of treatment, and I have been very fortunate, but when it does come, I think treatment options are very, very limited. The FDA have approved an antibody drug conjugate to stosumab, but we don't have access to that here, and I'll certainly be looking at trials if there's any trials. We've got some early phase trials, I think, in Scotland of patients who have progressed, but I haven't been in that situation yet. I will be soon, I'm sure. And if Axel can recommend anything, I'd be delighted to hear what he's using, but I think we're really struggling.
I think is the answer.
Yeah.
And then, clinical trials.
Yep.
Okay. This was a question from me. So something I struggle with is when patients ask about the Paula study or they're eligible for the Bev and olaparib combo, how do you communicate that uncertainty to them? So we know that we don't really know the benefit of Bev beyond olaparib, but how can you communicate in a way that a patient can understand and make an informed choice about what to go with?
Yes. I don't know whether the patient always understand because it is complex. I talk about, PARP inhibitors. I think they should definitely have. There's another drug that may help that has been approved previously. The trial's been run the wrong way around. If you believe that more is better and that you want to have had access to all drugs, then perhaps bevacizumab or olaparib is for you. If you want to go with the actual data that we have, then perhaps you stick with just single agent PARP, and then you get a feel for where the patient sits. And if they say, I need to know I've done everything, then you probably end up with olaparib Bev. And if they say, oh, do I really have to come in every 3 weeks for drip chemo or for drip treatment, then you know that you're much better off using PARP inhibitor. It is really unfortunate. My reluctance to use bevacizumab with olaparib is based on PARP inhibitors are incredibly well tolerated, and for certainly BRCA mutant and to a degree HR deficient, that's what they need to have. If bevacizumab adds to that, I want to know about it. I'm not reluctant to give both drugs. I'm reluctant to give both drugs with additional toxicity if I don't know that the additional toxicity is warranted. That's where the challenge lies. It would be lovely if they had done the 3-arm study. You could have even been clever with BRCA mutant is olaparib plus minus bev, HR proficient is bev plus minus olaparib in a 3-arm study for the HR pro. Whatever. But anyway, we didn't get that. So at the moment, I'm still grappling with this. It's difficult to communicate because it's not clear cut.
Okay, sounds like keeping it simple is the best thing. Have you chosen to stop bev in patients who were started on this pre-op if they were then found to have a BRCA mutation in favour of changing to maintenance olaparib? Or are you generally continuing both in the maintenance setting?
So if patients are on bev, I have the discussion about the data again, and we end up with a consensus. And to the degree, because I mean, typically in Bristol we haven't used bevacizumab pre-operatively, and therefore, I mean, again, there's an element of historic hangover. If you only have 18 doses of bevacizumab and the benefit is really in the maintenance, then I don't particularly see why I would want to use that in the pre-operative setting. ICON 8B has shown us that it's probably safe, at least in large cohorts, and on average. But until then, we didn't have that data. So we always chose to do it after surgery. And therefore, if you did germline and tumor BRCA testing at the beginning, you never really were left in a situation where you had to choose, you start bevacizumab and then have to take the patient off it. If you've ended up with having started it and then find out their BRCA status, I would do what I would do as in the truly adjuvant post-chemotherapy setting, and discuss the pros and cons, and then the patient can make a choice.
Okay, last question in the chat. So if anyone does have any final questions, if you can post them now, otherwise we'll wrap up after this one. Someone's inquiring about the longest duration that you can give olaparib.
It is indefinitely if you have residual disease at the end of chemotherapy. So if you've had what they class as a partial response, in other words, I suspect a surgery that didn't remove everything and then chemotherapy didn't get rid of that, then you are allowed to continue olaparib, a single agent in BRCA mutant patients, indefinitely. In Paola, it was 2 years, but there is something around, if in the opinion of the investigator there's still an ongoing benefit, you can also continue that. I think, can't remember, but I think it's no, can't remember. But 2 years, unless it was partial response and residual disease, and therefore you can continue indefinitely.
Okay.
And I must say, I typically do stop at 2 years, because the longer you treat, the higher the rate of myelodysplastic syndrome. It is not high, but it's not zero. And if you don't have evidence that longer is necessarily better, look at bevacizumab, we thought there was a very rational argument for that, and then it turned out to be not so. You don't really want to give your patients a second malignancy when they might well be disease-free at 6, 7, 8 years, even if you stopped it after 2 years of treatment.
Definitely makes sense. Okay, so I think that's a good point to wrap up. So thank you again to Dr. Stllie and Dr. Walther for their excellent talks this evening. I really enjoyed them personally, and I think lots of people will have found them very valuable.